points. Remember, next week we're gonna definitely sanitize and you would wash your hands and so forth. Identifying the patient verbally and armband. Okay, again, the critical points for this and for next week. I guess I'll be a nursing student today. Okay, all right. So my patient's in the proper position, right, to be able to do an abdominal assessment. So I'm gonna walk in. Oh, critical point. Gotta make it. I won't go and sleep like you will. Okay. Hi, how are you?
I'm good, how are you?
I'm good. My name's Angie Greathouse. I'm a development nursing student. I'm here with my instructor today and would like to do an abdominal assessment if that's okay.
Sure.
I will let you know that I'll be inspecting with my eyes, but I will also I'll let you know everything I'm doing when I do touch, and I will be pushing a little bit on your abdomen. Is that okay?
That's fine.
Do you have a full bladder?
No.
Okay, that's a good thing. So,
I don't think so, I'm not sure.
okay. But first, what is your full name, David?
Courtney Russell, 10/28, and I'm not telling you the year.
Not very compliant. I'm
X.
documenting that.
XX.
Okay, good job. All right.
Apparently, if you're born before 96, you're old.
You know what?
Yeah. One of them said it.
1973. I'll be glad.
Okay, beat me.
All right.
Was not me.
What did you say? I'm afraid I want to hear it too.
Yes, it was.
Okay. All right. So you're in the correct position, supine on your back, and so have you been eating? Have you been eating okay?
Yeah, sure.
Okay. Bowel movements are okay.
Mm-hmm.
Okay. Go regular every day. Is it okay?
Once a day.
Okay, once a day. And is it usually form soft?
Warm, soft, brown.
Okay. Thank you. All right, so I'm gonna do a little inspection just with some eyes, and I'm gonna get down on your level here and just make sure there's just no really big pulsations and a good contour.
I can feel my aorta pulsating.
Okay, I'll be looking at that. Okay.
I don't know if you all can see that, but I can feel it.
Yeah. So what she was talking about too, and before I do anything, because remember with the abdomen, we don't want to touch anything until we listen, right? So with auscultation, make sure we don't mess with anything. I don't see anything abnormal at all. I do see where her aortic is present and pulsating, but not abnormally, okay? Umbilicus, have you ever been told you've had a hernia or felt a hernia? Okay, so do you do any exercises like sit-ups or anything? Okay, and when you sit up, you don't feel anything bulging around the belly button and umbilicus? Okay, good. Okay, so any scars? She asked me not to raise your shirt, so I'm gonna ask her. Do you have any scars, tattoos, any rashes or lesions I should be worried about?
Just C-section scar.
Okay.
Like, yeah.
And down low, and those are usually down low. And transverse guys, okay, because obviously things we gotta pull back and get to. So that's your inspection right there. I would say flat and very normal again, no abnormal pulsations. Again, saw the aorta, but nothing abnormal there. Okay, now the next thing again with the abdomen, we're gonna make sure we auscultate first so we don't bother anything. Now is where my stethoscope. If I was to do in the hospital, you would want to do skin to skin if possible. But again, we would ask the patient and check with our instructor too. But she asked me not to do that, so we will not do that. And I want to start over in the right lower quadrant because that's where my ileocecal valve is, correct?
Yep.
I hear him right away. If I didn't hear him, you want to listen for at least a full minute. And then if you didn't hear him in a minute, you want to listen for almost a full 3 to 5 minutes. Really, 5 minutes is what you listen for. And if you don't hear him in 5 minutes, you let somebody know right away because it could include bowel obstruction, something going on, okay? You let me know if you have any pain during this, okay? Hers are present right away. You
is a good time to assess bellies, cause hopefully all of you just ate.
Yeah. So you wanna do all 4 quadrants, guys, starting in the right lower quadrant, like I said, where the ileocecal valve is, okay? The other thing too that I'm gonna assess or auscultate for are what we call breweries or brutes, okay? And you wanna make sure the aortic, like even though I saw no abnormality, you still wanna auscultate for that, make sure. Sorry. Sometimes I close my eyes just cause it's better. Okay, sounds normal, no breeze noted, no abnormalities there. Then what I'm gonna do next is the renal. You do renal bilaterally. Obviously the aorta is right here, and then let's see. There we go. You okay?
You said, Hopefully I don't have a brewing.
No, we're good. So the renal arteries, don't hear any breweries. Then we're going down towards the iliac, right? The iliac spine, think of it that way. I place my hand just so I can get the scope in the right place on the iliac, okay, where it's going down to the iliac spine, guys. Great, it sounds great. You don't have any abnormalities there, no breeze or brutes, okay? Tell me a situation where I might hear a bruit or a bruit. Anyone? What did you say? What'd you say?
Where?
Huh?
Where you would hear one?
No, why you would hear one.
Oh, here.
There's a partial obstruction.
Absolute partial obstruction. What about with the aortic?
AAA.
Aortic dissection, okay? So those are good examples to get when you get your med surgery. Alright,
Get to
next.
med search.
Yeah, that's good. I like to mention things, you know. Now I'm gonna do some light and some deep palpation, but if you're ever uncomfortable, please let me know, okay? So she is right now appropriate for the palpation I'm gonna do on the front, okay? Light palpation you wanna do for tenderness, guarding, and any masses, cause you really masses, the ones you would feel without any x-rays, can be done with some light palpation, okay? So I just kinda go across. I don't feel anything abnormal.
Muscles.
I feel those muscles, so sit up, not feel when you do your sit-ups. So did you see, I only go about not even more than a half inch when you do light palpation, guys, okay? It's 1 to 2 whenever you're doing deep palpation, okay? Now, the other thing that for rebound tenderness, when I'm testing for that, what could it indicate? It's on your sheet. Inflammation, right? If any light palpation even was to hurt her, okay? So you wanna make sure that they don't say, ow, quit doing that, things like that, cause inflammation can be definitely detected on light palpation. Never say always, never say never, but that's usually the case. And you can add to that if you like, but. And she didn't rebound like when I did it and when I would come up. So rebound tenderness is if I was doing light palpation, but then when I would bring my hands up in any area, and she was to say out that time, then again, we would be careful for that as well with inflammation. And then of course, when we get down to the other areas as well. If you do notice any masses, which in my field, of course, that's what we notice. You want to do location, exactly where it is, which quadrant it's in, if it's near the aorta, if it's near the renal, anything as far as you're talking about anatomy wise, okay? And then the other thing too is size, shape, tenderness, any abnormal pulsing like we talked about, okay? And mobility. Can you move it is the big thing with masses, okay? And if they have pain with it, tenderness, like we said. Now the special techniques, like we were talking about, in this Phil, appendicitis, gallbladder, that's why she had to do that. I'm gonna go on and do the front, for the appendicitis and gallbladder, and then I will turn her around and show you on the back with the costal vertebral angle tenderness, and it's bilateral on the back. So we'll finish up the front, and then I'll turn her around for you, okay? Okay, so where's my appendix, guys? We just did this.
Right lower.
Okay, and so when we talk about the appendix, remember on the right side, good job guys, by the way. And it's been a while since I've done the rosy side, so sorry. Okay, so yeah, the sides, because I always get it. If it's this side, yeah, right here. So I'm gonna press deeply on the left side. If she has pain on the right side, that's that roasting, some people pronounce it roast, that's that signs, okay? So you let me know if you have anything, okay? So if I was to press there at all and she had pain on this side, that's that sign, okay? And you correct me, because again, that's been a while there, was that, okay,
Yeah.
great, thank you. Now for the psoas sign, we're gonna bend the leg. I won't do both sides, but you know, with this one, we're gonna lift, I said bend, we're gonna lift her leg for the psoas sign, and when she lifts it, I'll press down, and then if she was to have pain on the side, on the right side, then when I do her leg, then that's when you would be concerned as well. And we're talking again, we're still on appendicitis, okay guys? Can I have you, I heard you to lift your leg? So I'm gonna have her lift her leg, right? And when I have her lift her leg, I'm gonna press down, and if it shoots up to the side, especially in the right side, sometimes it can come over, but mostly it's definitely 90% of the time all right side. And as she's lifting, if I'm pushing down and trying to push her leg down, and she has that could be an indication of appendicitis, okay?
I'm Tom today.
Yeah.
Watched it
Oh, did you?
yesterday, and his name was Tom.
Oh, okay, gotcha.
I do not have appendicitis.
She does not know. Mine's gone. I have nothing left but what I need, so we're in good shape. You would not have found anything on me at all. And then on the obturator sign, we're gonna flex and her knee and her hip and turn it inward. And if she was to have pain on that right side, remember? So I'm gonna have her see if that hurts. Does that hurt at all to flex your hip and that? I'm gonna turn it inward, right? And if she was to have any pain at all right there, that could indicate appendicitis, okay? This right here, you okay? Don't tell me you got pain. You can't have pain, okay?
Back spasm. Okay.
I'm gonna get there. Okay, you all right?
I'm good.
Okay. So those are your indications for appendicitis, okay? A lot of times the flex of the knee especially, and that, it will happen right away. Like, there's no indication. When they did all of mine, yes.
If somebody has already had a known appendectomy,
Yep.
and would you just skip all those
Oh, yeah.
exams? Like just because they don't
Yeah.
have it?
I tell,
Okay.
trust me, I have it, that's why I had to, I'll be honest, I had to review with the when you're talking about the roasting spine and that, I had to review that again because I haven't had my appendix for 12 years and haven't had my gallbladder for 10. So like people, they were like, when I told them that, they're like, yeah, we don't need to do those things, so yeah. Yeah.
Well, honestly, you're not gonna perform these on every single person.
Right, true.
You're only gonna do it if they're complaining,
Right.
usually of abdominal pain or specifically right lower quadrant.
If somebody has right lower quadrant pain, is there one of these three that is? Do you do all three of them, like in real world, or would you just? Is one better than the other?
It's good practice. You add it. If
I
you
think
wanna
it's
add.
good practice.
I
to
think
do
it's
them
good
all.
practice to do them all.
Okay.
Personally, I've done them all. Again, it's just been a little bit because usually most of my patients, they take the appendix out when they do the surgery and things like that.
Right.
But it's good practice, especially to get to know them in the clinical areas and that. Absolutely. Yeah. Yeah. Good job. And we all know that itis, that's what we're talking about, the cholecystitis with the gallbladder and the appendicitis. Itis is inflammation. So we're checking the inflammation throughout the abdomen with all of this. Okay, guys? All right, now it's gallbladder time. Woohoo! Okay. So where do I want to check for my gallbladder? If we did the appendix with the right lower, where are we going to check for the gallbladder? Okay, good job. Okay, so now I'm gonna get under your
My
rib.
tickle. Okay.
Sorry, I'm gonna get, is that your tickle spot?
Maybe.
Sometimes, okay. So now I'm gonna get under your ribs, okay? And on the right upper quadrant, and make sure your gallbladder's, doing okay? Alright. She's like, whatever. So let me feel for there. So here's where I can feel, and I'm gonna get a little deep palpation right there, okay, guys? I'm gonna push some deep palpation. Does that hurt at all? So we're good. She would have done 1 or 2, but I went on and did complete. I did 3 there. Okay. Let's see. Anything else? That was Murphy's sign, by the way. I didn't mention that either. Okay. And she would have, but it's under the ribs. You got to make sure you get into those ribs. Okay, guys. Any questions on that? Was that okay? Did anybody want me to redemonstrate? Yes.
For the palpations, are you doing them like twice?
I do because it's good practice again. But usually, if she's got some inflammation there, trust me, it did not take twice for mine. But with some patients, if it's just starting with inflammation, I'll let mine go too long. Imagine that. But if it's just starting, a lot of the times, twice may be indicated. Okay, and you might not be going deep enough on some of these. Okay, so just make sure. But light palpation across anything with the abdomen, like I was doing light palpation. That's what indicates if you're gonna go deeper and what you're gonna be checking, if that makes sense, okay? Yes.
And our patient should hold their breaths. We should tell them to take a deep breath.
Oh, you're so right, I forgot, good job, yes. Take a deep breath, and that was, that is a good practice as well, and I apologize for that. I didn't, yes, you want them to take a deep breath, because as they're taking a deep breath, think about it. It's gonna show even more and sooner probably, then you won't have to go as deep as well. Good
Talking about
question.
for Murphy's sign.
Yeah, you're talking about Murphy's sign, right, honey, for the gallbladder? Are you talking about for the Murphy sign? That's when you
Yes.
ask them to take a deep breath. I did forget to ask her, yes.
On the Robson sign,
Yep.
however you say it, why does that happen? Like when you push on the left, why do they get pain on the right?
They
Is
call it
just-
radiating some
Oh, okay.
some of these areas, and you can add this if you want. But what I was taught by my mentors and the doctors I work with, and how they indicate to take them out as well, when they have visible when they get in there, is when it radiates, especially because it can radiate across, and that's the sign that can do that. Yeah.
Cause everything on the other side
Yeah.
makes more sense to me if you're moving
Right.
stuff on that side.
That is the only, well, never say never, never say always. But 90% of the time, if that sign is positive, it's gonna radiate very quickly.
Okay.
Like on your first,
Push.
palpation,
Okay.
usually, and second definitely, yes.
And also because if it's possible that it's suspected they have appendicitis, you don't wanna be palpating that spot anyway, so.
Yeah, that was kind of what I was saying, basically, where you don't have to go further, absolutely.
You usually with appendicitis, at Bernie's point,
Yes.
a provider just even touches that,
Yes.
most people will wince. And immediately
Yeah.
you will stop palpating there.
Yeah.
You may do the other exams, maybe to get confirmation, but if they're having tenderness there and it is suspected, like I could barely touch when you saw Tom on the video.
And when I had mine, I let mine go 3 weeks,
Oh,
and by the time mine was almost ruptured. So yeah, he barely, he took 2 fingers, the doctor did at Baptist emergency room, and I was coming over and puking on him, let me just say that. So yeah, if you let it go too long, yes, Chelsea.
When you were listening, or
the aorta, or the abdominal aorta is about halfway between the xiphoid process and the umbilicus, so that would be in the upper
So that's
quadrant,
why I
or
did
in the
like-
middle.
That's why I was right here for the aorta, like more of the upper.
And then the renals, so your renals are in your upper quadrants.
So that's why I went from here and I went here. Sorry she was flat, but yeah, and then I went across. Yep.
So you just use the umbilicus as your guide.
Yeah,
And then
good.
you kind of just go down in the same spot a little bit below the umbilicus for the iliac. So
And
those
if
would
you-
be in the lower
Yeah, if you
quadrants.
notice her iliac spine, right here, that's why I was doing that. And then where I was with the iliac spine and the iliac arteries, okay? Alright, sorry about that. Does that help, Chelsea?
Yes.
Okay. Anybody else? I wanna make sure everybody's questions. Sorry if you couldn't see that, could you get that? Okay, okay. Alright, now. last one.
Yeah.
Yep, that's what I'm looking at now, right here. Yep. Huh? I'm gonna be, yeah. Let's see. So the CVS, the costovertebral angle tenderness, or CVA tenderness, you can call it that. And a lot of people, we think CVA is only like stroke, right? But you could call it CVA tenderness. So this is different than CVA cerebrovascular accident, okay, guys? So a lot of things, that's what's so important about these midterms. You don't want to get those mixed up, okay? So on her back, and this is what I haven't done in a while. So I'm gonna do like a knocking, yeah, right there. Okay, I'm gonna do a knocking sound, okay? You ready? You okay?
Yeah, I'm good.
Okay, so right here, if that causes any pain, you wanna make sure that is that causing any pain? Okay. You okay?
Yeah.
Alright, so you wanna knock pretty well, and if you knock about right here, it shouldn't hurt your hand and then it shouldn't cause any pain, okay? And again, that right there is a special technique. I will tell you, the last time I did that, it's probably been 10 years ago, to be quite honest. I had to, like, that's the one that are like ultrasounds, yeah, right?
They have ultrasounds. and
That's what
CTs.
ultrasounds are for, and CTs, and to see, and that's what ER doctors do. They'll do the assessment, and then they'll go to ultrasounds and CTs. A lot of times CT is to see if they need to do surgery. So, Argan, your costal margin from the front, and go like right here, your costal margin, and follow it around, and that gives you right there, about the 212. Okay? Good question. Yep, and but you want to do bilateral on that as well. Okay? Yeah.
How many times should we knock?
11.
Literally, it'll take, if you knock it, once you get it down, again, it's a very special technique, and once you get it down,
If they have
Yeah.
tenderness,
they're
tell
gonna
you
say it on number one, trust me.
Since the
Number
ride is
two.
lower, oh sorry.
Sorry? Yes.
Since the ride is lower, does that mean you go down a little lower or no?
You could, but
could.
you're still in the general vicinity of where the kidneys are.
So literally from here to here,
You have to
guys.
think about how big your hand is too.
Yeah.
And how much, you know.
Like some people do feel like